Welcome back, everyone, and thanks for joining us for this session entitled Fraud and Abuse Risks and Compliance, COVID-19 edition. Your speakers today join us from Hooper, Lundy, and Bookman. They are Scott Kiepen and Mark Johnson.
Good morning. My name is Scott Kiepen. I'm a partner at Hooper, Lundy, and Bookman in San Francisco. Along with me is my partner, Mark Johnson. Welcome to Fraud and Abuse Risks and Compliance COVID-19. I'm going to turn the floor over to Mark to give his brief intro and also introduce the topic and the substance of our conversation today.
Good morning, everyone. Now, we've been doing a similar presentation to this for, at least the last 4 or 5 years, at least once a year at the CAHF conferences. So many of you may have attended the presentations in the past. We're going to shift it up a little bit today because of the pandemic and the unique issues that pertain to that. So what you'll see is we're still going to briefly talk about some of the specific government investigations and state and federal laws, but we're going to focus more on some of the COVID-specific issues and compliance issues that we see those investigations likely pivoting to. We also want to expand upon the multitude of different types of agencies, local, state, federal, and then private actors that are getting into this game and that we anticipate seeing over the next 12, 24 or so months looking into this. So we'll touch upon the Federal False Claims Act. We'll touch upon some of the state laws, but we're not going to talk about active cases in those arenas like we have in the past. We'll maybe get back to that next year or the year after. We want to make this more COVID specific. So we'll talk briefly about the types of investigations that we're seeing out there and some of the relator type organizations that might get involved. We'll talk about basically 3 laws that we think that they will likely utilize to go into those investigations to issue subpoenas, civil investigative demands. There's 1 federal law, 2 state laws we'll talk briefly about and how they will utilize those for purposes of investigations. And then we'll dive into COVID issues specifically. We're going to start with waiver issues because, as we all know, starting back at the beginning of the pandemic, in March, April, May, there were all kinds of new waivers and requirements coming out. We're going to focus on the 3-day stay waiver, the benefit period, the extension of a benefit period. We want to talk about risk areas there, what best practices providers should engage, because absolutely you can be certain that there will be audits for providers that would be particularly ones that are outliers for purposes of Medicare days. And you can see, again, private relators looking into the stuff, the government looking into it. So what are practices we can do now to try and shore up documentation and to mitigate risk? Then we'll move into the CARES Act funds. There's been a deluge of federal and state funding that's out there. The federal funding coming obviously from the CARES Act. And that's a good thing, obviously, but the audits will come. We are all attesting to how we're using these funds. We are going to be submitting documentation in early next year and mid next year. Hopefully we're through this by then. And so those audits will be coming. You need to know now how you should be spending that money, how you should be documenting. So we'll talk a little bit about the guidance that's out there. And I want to talk very briefly about an executive order that President Trump put out in May that was expanded upon slightly in a memo from the Office of Management and Budget that I think is interesting and bears on the types of investigations that we may see. But we'll touch really briefly on that. And then lastly, we'll talk about compliance programs. We've always had that as a piece of this presentation. Depending on time, we may not get to all the slides in that section. So we'll just have to see. But as we said in the past, we like to include those slides because they have some basic information that is always helpful to understand the basic structures of a compliance program. You all know that we could do an entire presentation on compliance programs if we had the time. So we'll try and keep that fairly quick. So we're going to go back and forth a little bit as, again, those of you who've seen presentations with Scott and me before, we tend to go back and forth. So we're going to do that a little bit. And I know with this format, it may be a little different, but we think it'll work just fine. So Scott?
Yeah, well, thank you, Mark. As Mark said, we will talk a lot about the COVID-related issues. But before we even get to that, it's important to understand, it's just as a backdrop, the issues that Mark and I have been talking about for a number of years now in an effort to increase the providers and the memberships understanding and awareness of some of the areas and issues of risk still exist. So as Mark indicated, as a foundation, but we thought we would start first of all just with a refresher, I should say, kind of a reminder that all the pre-COVID investigations that we've been talking about for a number of years still exist. And as probably the starting point, you can just note that the Department of Health and Human Services Office of the Inspector General, the OIG, they still continue, or the OIG continues to issue broad-based subpoenas to skilled nursing providers seeking information regarding therapy utilization. So here we are now as a provider community, well into PDPM. Yet, despite that, and also now in the context of an unprecedented pandemic, as Mark indicated, dealing on the front lines with this incredibly difficult virus. But on top of that, though, we still continue to face investigations that existed pre-COVID. So, for example, subpoenas from the OIG seeking a broad range of documents, sometimes for periods up to 7 years. And they're seeking patient medical records, therapy policies and procedures, financial bonus plans tied to Medicare utilization, list of current and former employees, documents related to marketing, advertising, and promotion, training materials, and so forth. So it's important to understand that those investigations still exist. And again, just to continue on the next slide, as you'll see, audits completed by the provider or consulting group or consultants related to the provision of therapy services, agendas and minutes from stand-up meetings, and so forth. Very significantly, all communications related to the above, including email and text messages. Now, the significance of that is to remind you that it still exists, that these investigations still exist, but that playbook, if you will, the notion of subpoenas from the OIG as well as others, we anticipate seeing similar conduct at some point in the future. It's difficult to say when, but we can expect to see some form of conduct similar to that deployed now in the COVID context to the same extent that it was deployed in the RUGS context. Furthermore, you have issues, as you see on the next slide, where we have historical, what we call whistleblowers, and that is an individual that actually worked for an organization and now can come out and offer the government some inside information as to some alleged conduct. But now what we're starting to experience is this cottage industry, what we call parasitic relators, or others might refer to them as professional relators, meaning that these are analytic companies, statistical companies that basically harvest data provided by or otherwise maintained by CMS, which of course in the context of COVID, it's going to be a tremendous amount of information maintained by CMS regarding providers. And what these analytic companies do is they use statistical analyses to evaluate and identify outliers. In the context of RUGS, they identified outliers in the way of length of stay, utilization, and so forth. And then after they identify these outliers, they in essence file a claim, or otherwise they might go out first, conduct interviews as much as they possibly can with former disgruntled staff, try to get some sound bites, if you will, that would otherwise suggest or it would be what they call indicia of fraud. And then say under those circumstances, this provider, given the fact that they're an outlier in certain metrics, whether it be length of stay in the context of RUGS or utilization in the context of RUGS, coupled with the indicia of fraud, some statements from some former employees and so forth, that's enough to go at least take the matter to the government to see if the government will intervene in an action, or otherwise, if the government declines, file something in federal court.
And Scott, if I could jump in very briefly, keep in mind, folks, that, for example, with regard to the PPP loans, all of the data of who got PPP loans is public. It's publicly available. You can go right now online and get a database that's about 500,000 different individuals and entities that applied for those and received those funds. You can bet absolutely data analysts like IntegraMed are going to be using their software, their data mining, to plumb that data and see what they can find. Now, the PPP is different than the CARES Act, some of the other tranches, so we'll go through that. But recognize that anytime they see a large expenditure of state or federal funds, these folks see an opportunity to see if people are compliant with the use of those funds.
Exactly. Next slide, please. So let's talk a little bit about the tools that will be utilized by these prosecutors as well as insiders, whistleblowers, or what we otherwise refer to as professional relators, or what I always like to use is parasitic relators, like we just talked about. First and foremost, the Federal False Claims Act. Now, Mark and I have been talking about this for many years. We've been trying to, again, increase the membership's awareness about what the Federal False Claims Act is. And you can see there the definition, very briefly, the key elements. Knowingly presents or causes to be presented a false or fraudulent claim for payment or approval, or knowingly makes, uses, or causes to be made or used a false record or statement material to a false or fraudulent claim. So the basic definition there, as you can imagine, it just means that a provider engages in a pattern of conduct where that organization is knowingly presenting claims that it otherwise knows to be false, or otherwise uses records that are false in support of claims. The other tools, the California False Claims Act, or other states have similar false claims acts. These providers, whether it be, or excuse me, the relators, whether it be the insiders, parasitic relators, or governmental prosecutors, will use the State False Claims Act as another means, if you will, of piling on to the Federal False Claims Act as a means of trying to file a case. As Mark said, more recently, we're seeing some activity, at least by a district attorney consortium, along with the Attorney General in the state of California, to use what's called California's unfair competition law. Now, that is a broad-based, consumer-oriented statutory scheme. So it was created by the legislature in California to protect consumers against unfair competition. In essence, it tries to deter unlawful business acts or practices, unfair business or acts or practices, fraudulent business acts or practices, and unfair, deceptive, untrue, and misleading advertising. And then finally, any act prohibited by this specific statutory scheme. Likewise, there's another broad-based consumer-oriented statutory scheme called California's Consumer Legal Remedies Act. That particular statutory scheme attempts to deter unfair and deceptive acts. But in essence, what these particular prosecutors are doing, you can advance the slide, please. This state Department of Justice, this consortium of district attorneys and the AG, they're using the UCL, or the Unfair Competition Law, as well as Consumer Legal Remedies Act and other charges. And they're started out by first looking at transfer and discharge issues, as well as staffing. While it started there, it has now evolved as they use the government code authority to issue, very much like the OIG, when the OIG issues subpoenas under for evaluating issues such as the Federal False Claims Act. This district attorney consortium and the attorney general is using their government code authority to issue these broad-based subpoenas to get records related to transfers and discharges and the policies and procedures deployed by facilities, as well as staffing. But now they're starting to look at a whole host of issues and looking under and looking at everything from care and so forth. They're also now, under the circumstances, starting to look at the way in which providers spent provider relief funds. So we're seeing these broad-based subpoenas. There was a recent case called Abbott Laboratories versus the people of the state of California. In essence, it just emboldened the district attorneys themselves, because it now allows district attorneys to go outside of their jurisdictional county and prosecute charges, if you will, or claims in other counties throughout the state. So it's a difficult situation, and it's, again, something we wanted the membership to be aware of.
Yeah, and keep in mind, when you look at the language for those state laws, as Scott said, it's extremely broad. In a lot of cases now, particularly on the private plaintiff side, you're seeing particularly the UCL, the unfair competition law, added as a claim, a violation of that unfair competition law, because it's so broad. Essentially, if they contend that you violated a single regulation while running your business, and in nursing homes, obviously, we have thousands of regulations. If you are in violation of one while running your business, you could potentially be in violation of the unfair competition law. But in the hands of the government folks, they don't have to have a person that is harmed. If a private plaintiff wants to bring a cause of action, they have to have a person that was harmed by your actions. to bring that case. That changed a few years back to narrow the scope of that law, but it didn't change it for purposes of the government. So this has become a significant tool for local and state officials, law enforcement agencies, and others to conduct investigations, very broad fishing expeditions. And what's been interesting is, in part, you have this district attorney in Santa Cruz who has sort of made it a bit of his mission to investigate a lot of the nursing home chains in California. And in fact, he was one of the folks that made a reference to the fact that he may begin looking at expenditures of provider relief funds, which technically wouldn't even be within his purview, but it shows how aggressive the local folks are. And one other thing to note about particularly local prosecutors, district attorney's offices, city attorney offices, they tend to be a bit more political than your Department of Justice federal folks. Okay, so that's one of the problems. When you get a district attorney in Stanislaus County suddenly sending out 30 subpoenas to every single skilled nursing facility because they just want to know what's going on with infection control during this crisis, not because they know there was an issue, but because they want to look into things. In part, one could argue that they're doing it largely so that DA can say, see, I'm out there protecting you. He has no nursing experience. He doesn't know what infection control is. That's the Department of Public Health. So we as attorneys are always skeptical and concerned when these local prosecutors sort of stick their nose in an area that we frankly think they don't belong and don't have the expertise. So laws like that are problematic. And then you get these state task forces like Scott just talked about, and then you get these sort of multidisciplinary task forces like the Department of Justice. They have these elder justice task forces they're comprised of Medicaid fraud control units, which would be the State Department of Justice here in California, folks from HHS, APS, long-term care ombudsman services. So just more folks that are supposed to be focusing on these things. So as it pertains to COVID, what we would likely see is these folks, and here's the locations of those, these folks will absolutely be looking at in the coming year or so infection control practices, particularly at hotspots, Los Angeles, where you had a number of deaths within nursing homes. You'll see investigations into what were the infection control practices of those facilities. So that's already going on locally, but you're going to see these task forces move to that fairly soon. Go to the next slide. And then we have this announcement back in March. And this was planned pre-COVID. So on March 3rd, earlier this year, the Attorney General of the United States announced a national nursing home initiative looking into grossly substandard care. Now, you'll all recall that we've talked over the years about worthless services cases where the services are so poor, so deficient, that it's tantamount to not providing any care. They are worthless services, and therefore billing for those is a false claim. That's the theory. All right. Now, we have always fought against that in the sense that, yes, bad things can happen. There can be a negligent nursing home. But if you provide a set of services for 6 months to a patient, and then near the end of their stay, they have a terrible fall because your employee messed up, was negligent, was incompetent maybe, and that patient is harmed and dies, is the fact that you billed for all of that care a false claim? Or should you be penalized with a CMP? Should you risk other types of penalties like decertification? Should you face a negligence lawsuit? Yes, all of those are fine. But does that really, should we be adding in the False Claims Act to that particular set of tools that the government has? That's where we think we need to draw the line. And then there's also recently been an appointment of Greg Shapiro, and Scott can add a little bit to this, but the chief of the Affirmative Civil Recovery Unit in the Boston U.S. Attorney's Office. Now, those of you that know much about sort of the healthcare practice within the U.S. Attorney's offices in the United States, Boston was one of the first places to really develop a strong healthcare bench to go after false claims issues in healthcare. And so this particular U.S. attorney or assistant U.S. attorney is known to be extremely aggressive. He has been appointed.
Yeah, and just
to CARES Act funds. Scott, go ahead.
Yeah, just as Mark indicated, the fact that Mr. Shapiro was appointed to this position, as Mark said, Mr. Shapiro was instrumental in developing, as Mark indicated before, the notion of the worthless services theory. So I think it's a message to the country, a message to certainly to the provider community, that when Mr. Shapiro takes over this position, we have to anticipate that it's going to be a situation that's probably going to lend itself to some questionable tactics, some questionable subpoenas and so forth that otherwise will, as Mark said, look like or appear like it's a fishing expedition and so forth. But unfortunately, under the circumstances, we just otherwise have to prepare for it and ready ourselves for it.
Now we're going to get into some of the waivers that were in place. So we're going to go over them, but the key is these are things that your compliance officer should be aware of, should understand the scope of the waivers. There's obviously a lot of AFLs that have come out as well. There's been significant updating of guidance as it pertains to testing of patients, testing of staff, frequency of testing, etc. We're not going to go into all of that, but your compliance officers should be on top of those changing, ever-changing rules and guidance. We recognize the challenges, but CAHF has put together some pretty comprehensive timelines of all of those. So do reach out to CAHF. Your compliance officer should be part of that reach out and be familiar with these. So we're going to, as I said before, talk about two waivers. We're going to talk about the 3-day stay waiver, and then we'll talk about the benefit period. Scott, you want to start with 3-day stay?
Sure. Why don't we go to the next slide? As Mark said, we're not going to talk about all the waivers, but let's talk about two critical ones. And starting first with the waiver of the 3-day qualifying hospital stay. Now, I think everyone is familiar with the fact that when the Secretary of Health and Human Services declared the public health emergency, it provided the authorization to waive certain requirements of the Medicare and Medicaid programs. And one of the key requirements for post-acute providers that was waived was this notion of the 3-day qualifying hospital stay. Also, you'll see on the slide there, I think for purposes of post-acute providers, waiver of the benefit period is also a material waiver. The end-stage renal disease and a SNF, it allows end-stage renal disease services to be provided for in a SNF rather than off-site. The telehealth waiver so allows for physician visits now instead of on a monthly basis to be done by telehealth. Waives the co-insurance and deductible for COVID-19 related services, and requires Medicare Advantage plans to cover COVID-19 related lab testing.
And now, just before we leave that, I'm sorry, and Scott, you're going to delve into a few slides on the 3-day stay, but I want to make a comment about the telehealth. We have absolutely seen now sort of an explosion with telehealth because of the pandemic, but telehealth has been growing for the past 2 to 3, 4 years already. So I would expect, while a lot of these waivers won't stay in place, I would expect maybe it won't be called a waiver, maybe it will simply be a change in the way telehealth works. But I would fully expect the continued expansion of telehealth services. And so that's something, by the way, to talk about in another presentation of how we can best situate ourselves to obtain good services from physicians while they want to utilize telehealth more, and whether we should be using physician extenders and others. So we'll table that for another presentation.
Exactly. Good point, Phil. Okay. With regard to the 3-day qualifying stay, again, emergency waivers at the qualifying health, I should say, there's a waiver now of the 3-day qualifying hospital stay under Section 1812F of the Social Security Act. Now, in short, it applies to, or otherwise those beneficiaries who are either dislocated, and this is very significant, or otherwise affected by COVID-19. Now, there's some language in the waiver that's a little interesting, and it actually indicates that CMS waives the qualifying hospital stay in order to provide temporary emergency coverage. So keep that thought in the back of your mind as we go through a hypothetical here in a few moments. But otherwise, when you're evaluating the 3-day qualifying stay, look at it from a perspective, again, of were the residents or beneficiaries dislocated, or very significantly, were they affected by COVID-19? Next slide, please. So in this instance, it applies to all beneficiaries qualifying regardless of whether they have SNF benefit days remaining. And also significantly, the beneficiary status of being affected by the emergency exists nationwide. So there's no need under the circumstances, to the extent that the resident was either dislocated or affected by COVID-19. There's no need to verify the individual status or eligibility, that is, or to qualify under the 3-day stay waiver. Next slide, please. So in that instance, the way to look at it, and again, we're going to talk a little bit about the compliance and how you can audit for this particular issue, but when setting up clinical teams and otherwise setting up clinical operations to evaluate your community to understand the means by which you can prevent COVID from entering your facilities, or if it does get in, how to manage it, beneficiaries may be discharged from the hospital early without 3 consecutive days and therefore be eligible, that is under the waiver. Beneficiaries may also be admitted to the SNF directly from one's home or from the home. They may be admitted directly from a hospital ER, or they actually can be skilled in place without the need for a hospital stay. So we provide this one example, and I think in hitting all these various bullets, I can try to go through them quickly, but we tried to demonstrate when evaluating clinical protocols and evaluating when you could use a 3-day qualifying stay, how it basically works. So you can see there on July 7th, 2020, Jane Doe, a long-term Medi-Cal resident, developed signs and symptoms of COVID-19. These symptoms include a fever of 101, dry cough, O2 sats of 87, and red eyes. A COVID-19 test sample has been collected, but the provider does not have test results. Now, at that particular moment, depending on who you talk to, one might argue at that moment that the resident, at least at that point, has met the criteria for the 3-day waiver by virtue of the fact that it would appear that they were affected by COVID-19. Now, of course, there's no certainty to that because you can have different conditions that otherwise, obviously the flu and so forth, that might reveal the same conditions. So depending on your own clinical protocols, one might say you've been affected or the resident's been affected by COVID-19 at that moment, or as we go down a little bit further in hypothetical, you'll see where I think at that point it's confirmed that the resident has indeed been affected by COVID-19. Bullet 2, Ms. Doe was moved into quarantine area of the SNF in order to maintain infection control. So good clinical practices following best practices. Ms. Doe requires the skills of a registered nurse to monitor for signs and symptoms of COVID-19 as well as her changing health needs. Again, the notion of early intervention with this critical patient population, certainly oftentimes with many comorbidities, early intervention is key. Ms. Doe meets Medicare skilled coverage criteria on July 7, 2020. Her physician signed an initial Medicare certification in skilled care on July 8, 2020 to be effective July 7, 2020. So we're going to talk a little bit more about the documentation, but again, very critical. You have the criteria by which you're eligible to waive the 3-day stay, but then you still need the documentation and you still need to meet the conditions of coverage to be skillable. Then you have test results received on July 10th showing Ms. Doe is positive for COVID-19. A 5-day MDS is completed on July 11th with a primary diagnosis of U07.1. She falls into medical management category. Now, at least at that juncture, I think everyone would at least concede that the resident has been affected by COVID-19 by virtue of the positive diagnosis. But as I said, one even could make an argument earlier in the process before the testing that they were affected. Again, it depends on clinical protocols and the evaluation and determination of the attending physicians as well. And then finally, the nurse wrote an admission note stating that Ms. Doe was placed on Medicare skilled care due to signs and symptoms of COVID-19, and the physician, for the protection of the residents both at the facility and the hospital, requested that she remain at the SNF. So in that classic hypothetical there, you see a situation in which the waiver of the 3-day qualifying hospital stay was properly documented and justified. Next slide, please.
So now we'll turn over to the benefit period, but just a couple quick points still on the 3-day stay. Let's think about why that waiver was created. Remember the intent of that waiver and why it applies to everyone. The initial intent of the waiver was to prevent a bed shortage in acute care facilities because there was a lot of concern about a significant surge in April and May that would cause hospitals to run out of beds. And at the time, with the little that we knew about COVID-19, the thought was that it's ICU treatment, it's acute care treatment, that's what's most necessary for treatment of COVID-19. And so get those beds open. And in fact, remember, while California didn't ever get too close to, a really low capacity in bed. In fact, California really surged up in terms of bed capacity. Other states like Florida got at one point, I think, in some counties to 1 or 2% capacity in acute care beds. So the intent was to get people out of the nursing home. And some people can argue we don't know why the qualifying stay exists anyway. But here it was, if they've been in the hospital for one day and they're going to need skilled nursing services, go to that skilled nursing facility. You can access your Medicare benefit without the qualifying stay. If you're at a skilled nursing facility and you need some additional services, you can, and you're no longer a skilled patient, but suddenly you have a skilled need, you can be skilled in place. If you're at home and you need some type of skilled treatment, rather than go to the hospital, you can go to the nursing home. So the intent was to open up those beds. The benefit period, while it is somewhat similar in that it lets people access additional Medicare benefits, it's not about getting people out of acute care beds. It was about specifically where patients' treatment was impacted by COVID-19. Whereas the 3-day stay, you didn't technically have to have an impact. Here it has to be impacted by COVID-19 or the public health emergency, I should say, so that, let's say, and you see the example here, a beneficiary has been receiving daily skilled therapy and then develops COVID-19 and requires a respirator and a feeding tube. Now, obviously, for the rest of that treatment, they're not going to be likely getting skilled therapy, depending on exactly what they're getting. It's unlikely that they're going to get any skilled therapy. And so if they exhaust their benefit, this waiver allows them to get an additional benefit so that they can access those services. So there has to have been something like that. So that's a patient that actually gets COVID-19. And then there's another subset of patients who may not actually have a COVID-19 diagnosis. However, their treatment was interrupted by the public health emergency. And those situations may be less common, but you may have a person who was receiving certain services. Maybe they were receiving therapy services, but because of the public health emergency, maybe for some period of time, they did not receive those services. They were put in an isolation unit. And so therapists weren't able to get to them and provide those services. This benefit, the extension of this benefit, is available for those individuals as well. Next slide. Again, if those are the subsets that it does apply to, then the others, people that had no impact, no change in their treatment, no impact by COVID-19, they're not going to get an additional benefit without having the standard 60-day when they're not skilled and they restart a new benefit. So that type of patient, if the treatment is the exact same, they're not going to get an additional benefit. Next slide. And we'll move kind of quickly through these because we put quite a bit of detail. But again, if the treatment is the same and there's no evidence of impact by the public health emergency, then they cannot access that waiver. So let's move on to the next slide.
Yeah, the point there, real quick, just to jump in for a moment, Mark, with any of the waivers, as we said at the beginning, recall that you will be and will be posting a tremendous amount of information that CMS will be holding and subject to what we call Freedom of Information Act requests from what we again the parasitic relators. There will be options and opportunities for individuals for many years to evaluate data and look for the outliers that we were talking about earlier when these statistical organizations do their work. So to the extent that a particular provider or an organization is availing itself to the 3-day waivers to provide good care and deploy best practices across its patient population. And we're going to talk a little bit about this at the end when you talk about compliance. But again, it's going to be so important. Again, the old golden rule of document is going to be so key because, again, to the extent that you are documenting the basis for the 3-day qualifying stay, the waiver of that stay through because a resident was affected by or otherwise dislocated by COVID-19, or as Mark said, a continuation of the benefit period, it's going to be so critical to have that documented as to the reasons why. And then also to make sure that you have good, solid clinical documentation from the attending physician to address the conditions of coverage, including orders and certifications.
Yeah, because you certainly heard stories at the beginning when these waivers came out of facilities, a 99-bed facility that has one patient test positive and they skill the whole building. That type of data, if a facility goes from 15 Medicare to 99 Medicare in a week's time, those spikes will be identifiable through data analytics at a later point. So that kind of stuff people will be scrutinizing. And so if your length of stay, which if you have an additional benefit, that's going to impact the length of stay. If those numbers spike, people are going to be diving into those. So those are exactly the types of audits that they're going to look into. This slide is primarily reminding folks that the Medicare coverage requirements still apply. These waivers don't waive the particular coverage requirements in terms of the services that the patient needs, and that they have to be skilled services, they have to be provided by someone with particular professional or technical expertise. So we don't need to go through all those, but let's go through a couple of examples, because in the FAQs, for those of you that have been following the issuances of the FAQs by CMS, one question that has come up throughout this entire process is a positive COVID test alone sufficient to skill a patient? And the short answer is no. However, there's a lot more to it, which is it's not the test itself that says this person can now get a Medicare benefit and is entitled, and the facility is entitled to bill Medicare. It's the fact that most likely that patient's going to have comorbidities that create a significant risk for them, because they have COVID-19, there's going to be skilled observation that the facility is likely going to be doing that needs to be done by skilled personnel. And that's where it turns to the documentation. So let's go to the next slide. You're still going to need physician certification and recertification. And then you need to have documentation that is individualized. So for example, if you have a patient that gets COVID-19 and they also have COPD, we know that respiratory issues are an absolutely critical one to monitor for purposes of significant decompensation for patients with COVID-19. That's a huge risk area. So the documentation better well say, reference that the patient has COPD, have specific notes about monitoring respirations, how frequently that is occurring and why that's occurring. That's the type of documentation that you'll want to see that's customized, individualized to that patient. Most of our patients are going to have multiple comorbidities. In fact, almost all of them are likely high-risk patients for COVID-19. So the ability to skill them because of a positive test is there, but it's got to be appropriate documentation supporting the services that are being provided. Scott, I think you're up now.
Sure. So the CARES Act. We want to talk a little bit about the CARES Act, talk a little bit about the provider relief funds that came as part of the CARES Act. Again, it's important to understand the optics. And the optics meaning you have a group of individuals, from prosecutors to parasitic relators to private relators to local to local district attorneys and so forth, all reading the newspapers, all noting, at least from their perspective, that the long-term care industry in itself has struggled to maintain and otherwise provide good care to patients during the context of the pandemic. They see them getting large funds of, or these large sources of funding from the Provider Relief Fund and so forth. So the CARES Act, I think everyone's familiar with it. I guess it's critical just for you to understand, when you have bad optics like that, there's going to be at least some interest by some of these folks to look into how providers spend that money, how much they receive, and then how do they do relative in the way of preventing, managing, and otherwise taking care of COVID with regards to their residents in the context of the monies they received under these various acts. So we know, of course, the CARES Act is the second major federal relief package for COVID-19. The $2 trillion CARES Act includes direct payments to American taxpayers, extended and increased unemployment benefits, new unemployment assistance program for self-employed workers, small business relief, federal grants to various businesses, and payroll protection program loans for small business. Next slide, please. And then, of course, we move to the provider relief funds. Now, I think everyone's familiar with these, or probably, if not, should be soon, in that the general distributions, the tranches to the skilled nursing facilities themselves came in phase 1, phase 2, and phase 3. The two general distributions, phase 1, and the cleanup, if you will, what we call tranches for change of ownerships and assisted living facilities, phase 2 and phase 3. The targeted distributions, 2 targeted distributions allocating to SNFs, again, very significantly, $4.9 billion. And then more recently, the nursing home infection control distribution for $2.5 billion. And then even more recently, another kind of incentive, if you will, or a program by which to incentivize providers to provide good care, another $2.5 billion. So when you have that,
remember, and let me just add one quick point there, Scott. And remember, to get each of these tranches, there's both an attestation that has to be signed, and then there are terms and conditions that are listed. And that's not all. Over the ensuing months, we have gotten trickling out different FAQs, frequently asked questions, that at times were contradictory. Then we got specific guidance that came out, and then it flipped. So for example, on the revenue shortfall issue, initially we were told that providers could use some of these tranches, not all, different tranches have different requirements, that they could use some of the tranche to make up for lost revenue. And it could be done on a quarter by quarter analysis. Look at Q4 of Q1 of 2019 and Q2 of 2020. You can do a comparison. Well, then they came out with a completely different system a few months later, which said, no, we're going to do this net operating profit calculator, net operating income calculation. Then they came out again and flipped back to the revenue analysis. Now it's a year-over-year analysis. So unfortunately, the needle has been moving, although on that particular piece, I think we feel good that it's finally stopped. But keep in mind, there will be more guidance coming out because there are going to be forms that the government puts out that the providers have to fill out. And that's where you put all of your expenditures on those forms. Those should be coming, frankly, anytime now. They could be here within days. So we'll be seeing those, and that's going to give us even more guidance. But it's been tough following the whole process, but you kind of have to keep on top of all of these. Scott?
Yeah, and the key is to remember that the stimulus funds that came from the provider relief funds, it's really to prevent, prepare for, and otherwise respond to COVID-19. So that's what the money was supposed to be spent on. And as Mark indicated, on September 19th, HHS released its most recent guidance on essence how providers are going to attribute and otherwise account for the money they received and how they can otherwise declare and otherwise report to CMS how they spent the funds. So as you can see there on the slide, there's going to be certain categories that you're otherwise going to have to report to. Now, right now, the portal is supposed to open in January of 2021. Expenses and expenditures that has been spent on COVID-19 up through December 30 of 20 is going to be reported by, I think, February of 2021. And there's some record that indeed they might even extend that reporting period out perhaps as late as like July 31st, 2021. As Mark said, there's a lot of moving targets on this right now in terms of how it's going to be reported, the expenditures, and in what form. But when the portal opens, understand that, again, that everything that's being reported is going to be subject to some form at some point down the road. Again, these analytical organizations looking at how those funds were spent. Now, in this instance, there's going to be kind of two buckets, if you will. There's going to be general and administrative expenses, so that otherwise spent for, again, the notion of preventing, preparing for, responding to COVID-19, as you can see there, mortgage and rent, insurance. If your premiums, for example, we all know that the insurance syndicates have, in essence, been trying to run from these particular issues. You might have exclusions written in any form of renewal that you're probably going to have to deal with, even if you can't or you can avoid any form of renewal, you're still going to have to deal with more than likely with very significant increased premiums. You might have situations with personnel, or be having to pay like certain increased expenses to get your staff just to come to work, some form of pay to compensate them for the fact that they are putting their lives and that of their families, in essence, at risk by coming to the facilities to provide the good care to your residents. Next slide, please. Fringe benefits. Lease payments, utilities and operations. Again, we know the reports certainly early on in the pandemic talking about poor ventilation in healthcare facilities across the country, the means by which to increase cleaning and sterilization and so forth, and then other general administrative expenses. So very significantly, when providers start reporting this information in the portal, whatever forms and whatever they look like, and again, as Mark said, there's still a lot of questions out there, what it's going to look like, it's going to be key that you're as accurate as possible, recognizing that this information is going to be subject to someone scrutinizing it beyond CMS. Same with healthcare related expenses. As I said, you had your two kind of general buckets. Healthcare related expenses is your other big bucket attributed to coronavirus 19. So in this instance, the actual healthcare related expenses incurred over and above what has been reimbursed by other sources. Supplies, we all know, of course, the supplies have gone up significantly and so forth. Equipment expenses paid for the purchase of equipment used to prevent, prepare for, and respond to the coronavirus. So next slide, please.
And I'll jump in here, Scott. And I know we've only got a handful of minutes left. So these are just some of the additional expenses. I think the main takeaway is we've been generally happier with what the more recent guidance that we're seeing. It has been more specific and covered things that we thought absolutely should have been covered, that some of the earlier guidance was very vague about and creating a lot of concerns for providers. Now keep in mind, there's also, you've been getting the 10% Medi-Cal supplemental payment, and that is, at least for now, right, supposed to be in place through the end of the public health emergency, which has just as of October 2nd been extended for an additional 90 days. And so that will go till mid-January. So you'll still be getting that Medi-Cal supplemental payment through mid-January. And you will probably have some period of time after that to expend those funds. So the CARES Act funds, you have until July 31st to expend. The Medi-Cal funds, you'll likely have into the first quarter of next year to expend. But the problem on the Medi-Cal side is we don't have any real guidance. We have what the statute talks about, but it's fairly limited. And so we're waiting for more specific guidance to come out from the state on that. But you need to have if you're a large organization, your CFO, if you're a small organization, your business manager, you need to have your folks tracking this stuff, because people are going to look at it. There will be attempts potentially to claw back dollars that they think weren't spent appropriately. So
maybe we should go to compliance, Mark. At this point, a few minutes left, or do you want to talk about the executive order?
Yeah, let me just talk very briefly about the executive order. I'll be quick. There was an executive order that came out in May that talks about various regulatory relief to try and support economic recovery. And while it's several pages long, it does talk about enforcement agencies and their investigations. And it has a good line in there that I want to read, and then we can go pretty quickly here, but actually it's on there. So and it talks about, by recognizing the efforts of businesses in investigations, when an agency is investigating a nursing home organization, a hospital, when the businesses are trying to comply with often complex regulations in complicated and swiftly changing circumstances, by committing fairness in administrative enforcement and adjudication. What that basically means is recognize that regulations are complex, that there are often gray areas, and the rule of lenity is typically from criminal law. When there is a gray area, when there is ambiguity in a law, that ambiguity should be read in favor of the defendant. So what this executive order and the subsequent memo are saying is that same law should be applied in these administrative investigations. So a lot of these false claims cases that we're dealing with, the government is telling those enforcement agencies to read the gray area in favor of the provider. And that's important for our investigation. So let's just talk briefly about compliance. We'll just go through a couple of slides and then we can wrap up. So you all have to have compliance programs now. We know that. We've talked about that quite a bit. So make sure your folks are familiar with 42 CFR section 483.85. Not every facility has to have a compliance officer, but every organization has to have a compliance officer. So if you have 20 facilities, not every one of your facilities has to have one. You have to have a compliance liaison at the facilities, and we can talk another time about what exactly that is. But your organization has to have a compliance officer and should be right on top of this CARES Act stuff, because this is such a critical thing right now, and we know those investigations are coming. So what the slides go on to do is give you some of the basic outlines of what a compliance program is, what types of auditing and monitoring you all should be doing. You should be looking at your annual audit plan, looking at quality of care issues, looking at the waivers and understanding those, if your organization took PPP funds, ensuring that you've certified appropriately so you don't have to pay those funds back, tracking the CARES Act provider relief funds, and looking at the supplemental payments that we've been getting in the Medicare program and making sure those expenses are delineated and segregated so you can certainly defend and not have to provide any money back to the government. So with that, I think we will close. Thank you all very much. I'll let Scott say a piece.
One more quick thought. If you're taking advantage of the waivers and availing, or providers availing itself under the waivers, audit those particular records. Again, good documentation is going to be critical.
Terrific. Thanks, Scott. Thank you, everyone.
Enjoy
the conference.
Bye-bye now.